Dear committee, dear audience, good afternoon, everybody. My name is Bertalan Tordai, and I would like to present you my progress of my research on the effect of migration on healthcare. This is it. I'm a physician and also a first-year PhD student at the Center for Translational Medicine. Me and my team share a vision to assist migrants and immigrants integrating successfully into the host society. And we would like to achieve it by identifying effective interventions for improving the health outcomes of the immigrants and migrants. We have two ongoing projects right now. Both will aim the same topic, of course. The first one is a broader scale. It aims the topic on a global level with the help of a systematic review and a meta-analysis. And the second one will be a little bit narrow, aiming the EU with the help of Eurostat Analysis. The first project is on investigating the cardiovascular risk among immigrants in comparison with the host population. Migration is a specific phenomenon. In 2020, an estimated 218 million immigrants arrived into the developed countries, while nowadays it's much focused on asylum seekers and refugees. The first generation immigrants who have already settled down in the host society, host population, pose a specific challenge to the healthcare system. It is an already known fact that the cardiovascular risk is currently declining in the developed countries. Avoidable mortality decreased by 57% across the EU in 25 years, but it still accounts for 11% of the percentage of the total healthcare expenditure of the EU. Meanwhile, it is not known that the influx of the immigrants impact this declining trend or how these factors vary among the first-generation immigrants. After we took a deeper look into the topic, we choose a selective prevention strategy, which aims at a specific subpopulation and a certain risk or risks. In our point of view, the first-generation immigrants and the main modifiable atherosclerotic cardiovascular risk factors, which are high blood pressure, high cholesterol, diabetes, smoking, and obesity, according to the European Society of Cardiology guideline. Our aim is to identify population's risk among immigrants. Therefore, we have posed the following clinical question. What are the levels of the main modifiable atherosclerotic cardiovascular risk factors among immigrants compared with the host population? To answer this question, we have outlined the following PECO, where population will be the adults of a country with a relevant immigration, exposure will be the immigration itself, the comparator will be the people without immigration in their lifetime, and the outcomes will be the main modifiable atherosclerotic cardiovascular risk factor, which I have mentioned before. We hypothesize that the main modifiable atherosclerotic cardiovascular risk factors will differ between immigrants and the host population, and if our hypothesis proves to be valid, then we can directly transfer the results to support the development of effective and efficient cardiovascular preventive strategies. We have done a search with two domains, one for the subpopulation and one for the outcomes. We have over 19,000 hits in 3 databases. After the duplicate removal, we still have over 14,000 hits. And this is the status of the progress of the first project. We have submitted the Prospero in 19th of November. We have ended the duplicate removal in a week, and right now the title abstract selection is on the way with the deadline of 15th of December. We are a little bit over than half of it. We've done half of it. The second project is on investigating the prevalence of the cardiovascular risk factors among immigrants in the EU. It's a Eurostat analysis. Eurostat is the statistical office of the European Union with over 2,000 statistical tables publicly accessible. Eurostat collects the data with the help of surveys, national statistical institutes, and administrative sources. Eurostat provides the data which it collected as macro data and microdata. Macrodata shows the information on country level, so it allows EU-wide analysis, and microdata shows individual level data. Cardiovascular disease is a significant health concern in Europe. It caused 1.7 million deaths in the EU in 2021. Meanwhile, the EU population has grown with to 24 million non-EU-born citizens, which represent 5.3% of the total EU population. There are three factors. The first is that the prevalence of the cardiovascular risk is declining in the developed countries, while it is increasing in the developing countries, where the immigrants come from. So the prevalence of the cardiovascular risk factors vary among immigrants and vary also between the European countries, and the quality, the incoming immigrants number and type varies significantly between European countries. This highlights the need to identify, to analyze this problem. So therefore, our aim is to analyze the cardiovascular risk factors among immigrants in comparison with the residents of the host population and EU averages. And we would like to adjust it for socioeconomic factors like age, education, gender, and age, education, gender, and the income, yes, the money. So to meet our goal, we have posed the clinical question: how do cardiovascular risk factors among EU immigrants differ from those in the host population, considering the influence of the mentioned socioeconomic factors? We have outlined a PO where the population will be the people of the European countries aged over 15 years. Exposure will be the immigration, and the outcomes will be the same as in the first project, so the main modifiable atherosclerotic cardiovascular risk factors. We hypothesize that cardiovascular risk factors among immigrants differ from those in the EU population, and they are influenced by the socioeconomic factors. If our hypothesis proves to be valid, then we can directly transfer the results for the society's sake to support specific preventive measures with the simplest and most financially advantageous way possible. So, summarizing the two projects, we have two projects aiming the same topic, one global scale and one EU scale. Both planned to be submitted in the autumn of 2025. Yes, and I would like to end my presentation with a quote from Jorge Ramos, who is a Mexican-American media mogul. The greatest nations are defined by how they treat their weakest inhabitants. Thanks for your attention.
Thank you. Question already there. Christina?
Congratulations on your presentation. You mentioned in your PO framework that you would like to include people at the age of 15. Why is this borderline, and from where did you get it?
Thank you for the question. Yes, because people over 15 are considered to be in working age. So that's why we will use this data, and Eurostat gives the data or divides the data according to this borderline or line.
Thank you.
Okay, next question.
Regarding your first project, I have to disclose I'm one of your co-investigators.
Yeah.
Going through articles, I noticed there is considerable amount of heterogeneity. That is, country of origin, age range, even the time when the article was done. For example, 2005, the outcome will be different compared to 2015. Acculturalization. So how would you tackle this amount of heterogeneity?
Yes, one of my partners in the terror selecting the articles. We have to still discuss this with the team so the subgrouping. But I have a plan. I have already mentioned it, but never discussed. I would suppose that we should subgroup the migrants, immigrants by the territory they are coming from. So we have large territories, Latin America, meaning South America, Middle America, the Caribbean archipelago, so for one, Sub-Saharan region, that's obvious, so Africa, the south from the Sahara, the Mediterranean, so the North African and Middle Eastern region, Far Eastern region, and Southern Asian region. And I don't know, we have to discuss the conflict of interest yet, but I think you have also met the problem that there are some small territories which cannot be implement these five large territories, and I was very surprised by the fact that a couple of dozens of articles are working or researching Inuits. I don't know if you have Inuits immigrating into the North Africa. I don't know why, but yeah, at least 20 or 30 or something like that. So we have smaller exclusions. We have to talk about that.
I understand. And just one more thing to mention, that there was a situation where a very specific kind of population exposed to Holocaust I had to exclude. So yeah, these kind of certain exposures, will be difficult to include in the final analysis.
But it will be interesting, yeah.
Okay, so it's a rediscovery of geography as well.
Yeah.
Okay, other questions?
Thanks.
Okay, thank you again.
Okay. One last question. Do you expect big differences depending on host countries, whether they arrive to Hungary, to South or to Northern Europe?
I would consider the developed countries as in the first project as one unit.
Yes, exactly.
As one unit. So no, and in the second, yes, I am waiting differences.
Okay. But we will see.
Yeah.
Okay. Thank you very much.